we call it immunotherapy, allergy immunotherapy, so that means allergy shots. And we call it IT for short, for immunotherapy. And this is Gayla Rogers. She's our head allergy nurse. So do you have until, what time? You have until 1:45 or 1?
Like 1:45.
About quarter, okay.
Yeah.
All right. So, well, between now and 1:45, we want to go ahead and, our main goal is to talk a little bit about the allergy shots and have you ask any questions that you might have. With the main goal being that you're just sort of more comfortable knowing the background and administering that allergy shots too, and sort of when you have to make adjustments, that kind of thing. So,
The microphone for Skype is the phone, so if you can kind of slightly direct the voice, they said they can hear you, but just barely.
okay,
Thank you.
sure. So, Gayla's gonna go ahead and give a little more introduction, and then we'll go from there.
Okay, so just before the patients get to you, we have a whole consent process that we review with them and tell them what to expect and how long they'll be on allergy shots. So we always let the parents know that it's going to take 4 to 8 months or 4 to 12 months in some cases to get built up to a maintenance dose where then they can spread their shots out. Generally, when you first start allergy shots, you get them once a week for at least 8 months, depending on what the schedule is, and then it can be spaced out. The families are informed that they have to get the shots in an office with the emergency equipment available or a physician available. You have to have epinephrine. No one is allowed to give allergy shots from our office at home. So it has to be done at a primary care office, or some urgent cares have given them, but it has to be done in a medical office. Even if they say, I'm getting them, they can't give the shots at home. And that it's for a safety reason, not so much that they don't know how to inject them, but it's more like how to handle a severe reaction is the reason, and how to cut back.
And that is even if someone's been getting allergy shots for 3 years. They're getting once a month, they're on the maintenance dose of 0.5, they've had no previous reactions. Every once in a while, out of nowhere, someone can have an anaphylactic reaction. And the risks are a little bit higher if there are pollens in the extracts, and say it's ragweed season, they're highly allergic to ragweed, and it's that time of year, then they're in some ways getting exposed to a little bit, they're getting exposed to their injection, and then they're also handling it. That's when people are more likely to have a reaction. But the guidelines, so these are national guidelines, and they recommend the minimum wait for every allergy shot is 30 minutes. There are some other offices who do not enforce that very well, but we feel it's important because every once in a while we will have someone who they've been doing fine, and then all of a sudden they'll have a reaction where they need epinephrine.
Yeah,
Okay,
that
so
30-minute wait is real important. We actually, after we give the injection, we write the time on like a whiteboard and have them come back in so we can check, not only just for a local reaction, just to make sure they're breathing okay, they don't have hives or any kind of side effect from the allergy shot. And parents know this. A lot of times they'll come in and they'll say, I can't wait after you've given the shot. We have to, be home to get my other one off the bus or whatever. And we make a note of that, so the next time when they do come, that we say, before we give the shot, are you gonna be able to stay? Because if not, we can't give you the shot. And that's just, for safety purposes, because actually we have had patients leave, and then, I know one particular, was a teenager, he left, got out to his parking lot in his car, and then started having trouble breathing. So that 30 minutes is really important. We used to say 20 minutes, and now it's been 30 for several years.
it's been 30 for more than 15 years.
Yeah.
So, and we find it helpful too, we have a whiteboard, and we'll write the name, and we'll write the time that 30 minutes is up. So that if there's another nurse, we have them come back for an arm check, and then, so if they leave early, then we'll know it because the name is up on the board. And if the one nurse is doing something else, the other nurse will know what time they're due for their arm check.
We also make sure the families are aware that their child cannot get an allergy shot if they're acutely ill, if they have a fever, or if they have asthma and have had trouble with their asthma, needing to use an albuterol inhaler in the past 24 hours, we'll hold the shot.
Are these mine? Can I write on them?
Yeah,
Okay, thank you.
there's actually a little nitty-gritty sheet I think has a lot of the same stuff we're talking about. I think a lot of that's on there. And then we review with them signs of a local reaction and signs of a systemic reaction. So, which we'll go into more depth in a little bit. So once they sign this and they say they agree to do the allergy shots, if they're not gonna get them at our office, we'll say, we're gonna come to Hilltop for it. So we send over a physician consent form, which is those orange sheets. They're white, I think when you get them, it's the same information, which is saying that your doctors agree to follow our recommendations and give the shots in the office. We do not make up the allergy vial, we get that back from your office. And then once that's made up, it takes, maybe 3 weeks, 2 to 3 weeks. And then they'll come to the allergy clinic for their first shot, and then we'll courier the medication to wherever they're getting it.
Okay, so, has everybody already been giving the allergy shots, or is there anybody who's sort of new to this?
No, yeah, I've not.
No, okay, but you guys, the plan is for you guys to administer them?
Mhm.
That's one of the reasons here. Okay, great. So let's go through the build-up schedule first. We've tried to make this as simple as possible, including color coding, but we realize that there's still sometimes other ways there are ways it can be interpreted where it might not be exactly as we sort of think here. But this would typically be what a new start would look like. Okay, so I think you can probably tell which is the gold dose, right? The concentrated vial. So that's this. So basically, if someone is allergic to cat, dog, dust mite, and ragweed, we'll go ahead and take a certain amount of each of those allergens from the cat, dog, dust mite, and ragweed vials, and we'll add it to this, and then sometimes we'll have to add a little bit of essentially water diluent. And then what we do is, like, each of these next set of vials are 10-fold dilutions, okay? So these next 3 vials, they each have diluent in it, okay? So sort of like saline, essentially. And what we do is we take half of an ml of this and put it into the 4.5 mLs of this. So then it becomes 1 to 10. It's almost like taking 1 ml out of and adding it to 9 mLs. So it's this is maintenance dose, so that's 1 to 1. This is a 1 to 10 or 10-fold dilution. You can see it's a little bit amber color. And then here's the next one. You might be able to see a hint of color in that, but we take 0.5 of this and put it in this, and then we take 0.5 of this and put it in this. The green dose, these are all color coded, so you really don't even need to look at numbers, okay? But the maintenance vial is going to be number 1, all right? And but we have pretty much gone to color coding because we think it's simpler. So anyway, the green is the starting vial, okay? And then you work up to the blue, and then the yellow or the amber vial, and then the red. Okay, so and these are for environmental allergens. So if this is 1 to 1, 1 to 10, 1 to 100, 1 to 1,000. So the very first dose, they're only getting 0.05 of that. So they're actually starting at 1/10,000th of the dose, of the gold dose. Okay, so it's almost all water. It's unusual to have reactions that early, but it can happen, okay? And if you look at this here, the doses start at 0.05 mLs. So out of a TB syringe, it's recommended, TB syringes are, you know what gauge they are? 27 gauge. And the needle length is half of an inch, or 5/8. Yeah. And so you draw up 0.05. So that's a very, very small amount. It's not even half filled, right, the TB syringe. And it's really important to make that distinction, that extra decimal point, 0.05 versus 0.5, because otherwise, if you drop 0.5, you're giving them 10 times more than they should. Okay, it's like, misdosing a medication by a factor of 10. All right, so you have to be really careful about that. And in an effort to minimize the risk that 0.05 and 0.5 was going to be mixed up, we, years ago, the goal dose for, like, let's say the green vial was 0.5. So it would be 0.05 first dose, 0.1 mLs the next week, 0.2 mLs the next week, 0.4 mLs the next week, and then 0.5 mLs. We've gotten rid of the 0.5 to try and minimize that risk for the decimal error, okay? So anyway, if you're, I think a maybe easy way to remember these color codes is that red is like caution, okay? Like be careful, like red light, stop, okay? And then the yellow or amber is like the amber light, so it's just before red. And then green is go. Okay, so go, that's the value you start with, and then blue is the only one left. Okay, so green, blue, amber, or yellow, and then red. Okay, so you start with 0.05, they come in weekly, hopefully, and then you work up to 0.4 mLs, and then it says discard. Okay, so once they get that 0.4 dose, you toss the vial. You don't keep giving them 0.4, okay, and because you want to continue to get them up to the scheduled maintenance dose. And then you go to the blue vial now, which is 1 to 100, and you start with 0.05 mLs. So the 0.4 in a blue vial would be 0.04. Okay, so so technically, if this said 0.04 mLs of blue, that would be the same dose as they got from the previous vial. So it's a very, very minimal dose increase when they go from 0.4 of green to the 0.05 of blue, okay? But it's the same scheduled workup, so those 4 doses, and then you toss it again. And then the yellow one, now there's a couple in between doses, okay? But you're ending with 0.4 again, and then you get to the maintenance vial, okay? And the first dose of the maintenance vial is the same, 0.05 ml, so a tiny amount. And then you end with 0.5. And now that they're on a maintenance dose of 0.5 mLs, it says continue 0.5 until empty. Okay?
So what happens if you're at one of the 0.4s and they have a reaction? You wouldn't discard it then, correct?
Oh, good question. So, yes. So, yes. Some offices will hold on to the vial to make sure, like for when they come back the next time, to make sure they did okay. I don't know if that adds any confusion for the next time, if you're not the MA, you're giving the shot the next time. If you see that.
Sorry.
So there is a dose adjustment schedule here on the back of the page. So it says if shot is overdue, you want to go through the shot overdue part?
Oh, you can.
Okay. So there's if the shot is overdue, and then there's also if someone has local swelling. So how to sort of do a dose adjustment. Maybe we'll wait for her on that.
Okay.
Why don't you go ahead?
Okay, so we're gonna come back to that one. Alright, so, talking about reactions on how to recognize and treat reactions. So, there's 2 different kinds. Probably the most common is a local reaction, and that just involves redness, might be itchy, might have a little hive there, some swelling. If it's nothing really huge, which it tells you on the back of this sheet, for any local swelling that's greater than 30 millimeters or like a 50-cent piece, you'll cut back a dose. If it's 2.5 inches, we're gonna cut back 2 doses. So most of the time, it's small enough, it might be like the size of a quarter, maybe a 50-cent piece. We don't do anything for that. A lot of times we'll just remind patients to take their antihistamine. A lot of these kids are on antihistamines like Zyrtec or Allegra, something along that line, to make sure they're taking it the day of their injection. That helps keep the local reactions down. Sometimes we'll give them an ice pack. In fact, first, new starts always want to always want an ice pack, and then every time they want an ice pack, even if their arm is fine. So we give out a lot of ice packs to put on their arm, and then if it's really itchy, we will use like hydrocortisone cream, or we'll tell them they can do that. Let's see, for a systemic reaction, that would involve any kind of respiratory distress. You know, let's say they're out in the waiting room, waiting their 30 minutes, and maybe they start with just like, you notice, and this is one thing that a lot of people don't really think about, but it happens, they'll start like scratching the palms of their hands, or the bottoms of their feet will start itching before anything else. And, you know, you may not really realize that that might be an early sign of a systemic reaction. So if you notice that, you know, you need to have them come back in, listen to them. Any kind of a systemic reaction that involves respiratory distress, if they're wheezing, they're gonna get epinephrine right away. That's the first thing. Epi, for any systemic reaction that involves respiratory distress, they're gonna get epinephrine. If they have, let's say they break out with hives, you know, that's significant for the next injection, but we may not give epi just for hives. It just depends on whoever our doc on call is. But as a rule, we'll give them some Zyrtec, and then, you know, get an O2 sat, get their vitals, and just kind of watch them. And if it seems to be getting worse, or maybe they're clearing their throat, or says it's hard to swallow, or they have lip swelling, anything like that, then we'll go ahead and give epi. You guys usually have a physician here, don't you, when you are giving shots? But it's really important that if they do have a systemic reaction, that you let us know, so that we can tell you how to proceed with the next shot. Because we may make a whole new vial, we may dilute the vial, we may just tell you to cut back, but it's important that we're aware of that so we can tell you how to proceed. So for any systemic reactions, you need to definitely call the office. For local reactions, if it's nothing huge, just treat it just, you know, like a local reaction, put an ice pack on it, you know, document it in here so we can see if there's a pattern in here when they get to a certain dose, if that's when they have the local reaction. And then if you're at all unsure what to do, you can always call us.
So we try to make what to do here black and white, but honestly, it's not always black and white. And, you know, if there's someone getting allergy shots from another practice here, you know, they may see something different. But I think, as an example, let's say that someone gets their allergy shot and they come back 30 minutes for their check, and their area of swelling is greater, 50-cent piece, about like that, right? It's greater than that after 30 minutes. So that says for local swelling, so then the next time, cut back 1 dose, okay? But let's say that they get their arm check and they have just like a little, really small hive. Then they go home, they come back the next week, oh, how'd you do? It's really helpful to ask how they did after their next shot, and are you having any asthma symptoms, any breathing problems? You know, it's sometimes better to say any coughing, wheezing, chest tightness, or shortness of breath, because to that you'll get a yes, but if you ask if they're having any asthma symptoms, it'll be a no, right? But if they come back and they say, well, my arm swelled up like to the size of my palm of my hand where I got my shot, we don't always cut back on that. You know, we ask them, well, did it bother you a lot? I mean, if it got really itchy, if it was burning, if they had trouble sleeping on that side, then we'll cut back. But some people come in and they're like, it was really delayed, it really doesn't bother me at all. You know, we will keep advancing the shot. So when you have, if that comes up and you're not sure what to do, just feel free to call us, okay? Because we want to try to be as helpful as possible. And like I said, it's not always black and white on that.
One of the things too, talking about reactions, you guys all have this orange sheet, which comes with the vials. When we send out a new vial, we always include this orange sheet. So it's really helpful if you keep this in your med room, so you can glance at it on how to treat a reaction. So it's everything is on here, like what I just talked about. You know, how they have to wait 30 minutes, how to give the shot with the 27 gauge. You probably use those TB syringes with the 5/8 inch needle. You want to make sure too that you're giving the shot in the fatty part of the outside part of the arm. So you're going to be giving it sub-Q. Okay.
Most shots that you give IM. Okay. Why do you think the allergy shot should be given sub-Q? Right, so you think immunization or medicine or allergy shot, you think it'll be absorbed quicker if it goes IM or sub-Q? So IM is much more vascular, there's a lot more blood vessels in the muscle. There are a lot fewer blood vessels in the subcutaneous or fatty tissue. So we want allergy shots to be absorbed very slowly, because if it gets absorbed quickly, people are much more likely to have a systemic reaction or anaphylaxis. So it's really important, especially like some of these kids, you know, these young children, they don't have much sub-Q tissue at all. So you really have to tent up their skin and you have to angle the needle in order to avoid giving it IM, okay? So it's really important for allergy shots, they should always be given sub-Q.
So, yeah, as far as giving epi, do you guys ever use the EpiPen? Have you ever had to use it in the office? You have? I'll start pass these around. I'll you guys
What do you have here? Do you have EpiPens?
EpiPens.
Do you also have vials? Just EpiPens, okay. And do you have both doses? Do you have the 0.15 and the
Yes.
0.3? Okay. So,
the dosing for that?
yeah, so if someone is, if someone is, let's say you're coding a patient, if you're like an inpatient nurse and you're coding a patient, how much epi for like a standard adult person are you supposed to give? It's how many, you give 1 milligram, right? So like a systemic reaction or anaphylaxis here, we don't give that much, it's not given IV, right? It's given, epi now is supposed to be given sub-Q or IM, if someone's having a systemic reaction.
I am.
IM, okay, and it goes back to, why do you want to give it IM?
There's super
Fast.
quicker.
Yes, because you want it to be absorbed more quickly, right? You want epi to be absorbed more quickly, but allergy shots less so. So you go ahead and, who has practiced, you guys have not practiced with a trainer, right, most of you? This
Yeah,
epi
I think
training?
it's part of our training process.
You have, okay, okay, great. And so if you give it IM, the peak absorption, so the time till the medicine gets to peak is 7 minutes. If you give it sub-Q, it's 34 minutes, okay? So if they're anaphylaxing, you don't want to be waiting around for probably half an hour, right? Waiting to see if it's going to work or not. And the dose is 0.3 milligrams for sort of your person who's at least 30 kilos. Okay, if they're less than 30 kilos, it's 0.15. So that's the epi junior dose, 0.15 milligrams. The regular epi injector dose is 0.3 milligrams. So 30 kilos is about how many pounds?
65?
Yeah, so an easy way to calculate, like if someone weighs 66 pounds, you go ahead and, if you want to convert that to kilos, you divide it by 2, so you're at 33, and then you take off 10%, so that's like just over 3 kilos, so that's 30 kilos. Okay?
So when you use the EpiPen, you always want to use it in the lateral thigh. So you never want to give it in the buttocks. It's always the lateral thigh.
Or the arm, so it's the thigh. You don't want to give it in the buttocks or the arm.
Right. So usually we have them lay down so we can hold them good. And then you're going to take off the blue cap. So as soon as you always want to make a fist, first of all. That's to prevent you from accidentally putting your thumb on the wrong end. So you make a fist, you take the blue cap off, and as soon as you take the blue cap off, it's ready to go. If you forget to take that blue cap off, it won't work. So you take the blue cap off, and then this orange tip is where the needle's going to come out. So you're gonna put it like right in the middle here. And you don't have to jab it, actually just kind of place it to your click, and it's 3 seconds now. 3, 2, 1. Then I know we're not supposed to massage, but we tell parents they can massage it. And then once this orange tip pops out, that is actually covering the needle. And then as a rule, if they're not better within 5-10 minutes, if they're not improved at all, we'll give a second shot of epi. Okay? And then I'm not sure what your process is if you have to give epi. Do you
I think we have to
call
call 911.
Okay, okay. Yeah, that's what we tell the parents too, and I'm not sure what it was on the offsite. There's also the AviQ, which this one is the one that talks to you and tells you how to use it. I know we don't have it here, but a lot of times parents may have this. And with this one, just to show you how it works, it's kinda cool. This comes out,
This trainer contains no needle or drug.
so it's
and
the
is
exact
for
same
training
drug, it's
purposes
just a different
only.
delivery.
Do not use this trainer during an allergic emergency. If place black end against outer thigh,
thing.
then push firmly until you hear a click and hiss sound and hold in place for 2 seconds. 2, 1.
The needle
Training
retracts. So
complete.
it's kinda nice.
This trainer may
You
be
guys wanna
reused for
play with that,
training
you can.
purposes. Replace the red safety guard and gray outer case.
It is, pushing a tiny bit more.
I think that
This
those are
trainer
actually,
may be
are they cheaper?
reused for training
Those are more
purposes.
expensive.
Replace the
I say, I
red
thought the
safety guard
EpiPen
and gray outer
itself was
case.
the most
Have it
expensive.
upside down.
It's not that uncommon
There you
for people in a panic situation. I think there's some, I think it has to do with like a pen cap. You take the cap off and people think the needle is there, and then they go like this. I mean, medical providers do it. They go like this, and then they go like that, and who gets it? And then the nurse is no longer concerned about the patient, right? They're concerned about themselves, so I'll be right back, hopefully. But anyway, so that's why we recommend fist grip, okay? Okay, so a few words on when to use epi, because that's another thing. We'd like to make it black and white, make it clear cut. We've tried to do that on this orange sheet, but it's not always very, very clear cut. Sometimes it is, right? If you're having severe respiratory distress. Sometimes we'll have parents say, well, do I give epi when, their lips are blue? Well, no, if you wait that long, you've waited too long, okay? So epi works much better when given early. And people make such a big deal about giving an epi injection, and there is the hassle of having to call 911, and the patient may have to be transported, right? But the excitement overall is much lower if someone's having a systemic reaction, and they get it early, because it is amazing, usually within a couple minutes, they're already improving. If you wait until they're really having bad respiratory distress, it may be harder to turn them around. It may take multiple doses of epi. They're also more likely to have what's called a late phase reaction. So, they're in the ER, and a couple hours later, everything sort of flares up again, and they need epi again. So there's sort of a little bit of a fine line between, no reaction, local reaction, and then there's systemic reaction, and then there's anaphylaxis. So in the example that Gayla mentioned, where she said, I had someone who got an allergy shot, and he was 8 years old, and he went out to the waiting room. He came back 10 minutes later with his mom, and she's like, oh, he's sort of itchy. Well, he was itching the palms of his hands. He took off his shoes because the soles of his feet were itchy too. And he had been fine. So was he having any itchy before he got the shot? No. He didn't have any other symptoms at the time, but that was clearly evidence that he was having a systemic reaction. That is something that we would give epi for, okay? We wouldn't give oral Benadryl, because how long does it take for Benadryl to even start working? It usually takes at least 20 minutes to get absorbed and start working. But we gave him epi, and within 2 minutes, he was so much better, okay? Because you're having